everyone. Welcome to the Physiatry Mentors. I'm Dr. Sheena Buba.
I'm Dr. Benicia Williams.
And together we are Shanisha. All right, so in honor of Spinal Cord Injury Awareness Month, we have two wonderful physicians with us, Dr. Felicia Skelton and Dr. Angela Rubin. Thank you so much for joining us. So they are SCI fellowship trained physicians who currently are working in the VA. So in addition to treating patients, Dr. Skelton, she is very prolific researcher, has done a lot of presentations and papers on various topics in SCI, as well as has a special interest in health disparities and women in medicine. So we'll go in a little bit of detail about that. And then Dr. Ruman, she was our upper level resident when we were at residency at Baylor, Dallas. And even then she loved teaching, and her lectures were always like the best ones that we've had.
Always. So good.
So we've always seen that passion for teaching and mentoring. And she is over at the VA in San Antonio and was actually awarded one of the Teacher of the Years. So not surprising there. So
congratulations.
Thank you so much for joining us. And we'll be talking a little bit about, why they went into spinal cord injury medicine and what it's like working at the VA. So thanks again for joining us.
Yes, ladies, we're so excited to have you. So tell us a little bit more about yourself. We want to know where you're from, your educational background, and a little bit more about your current practice. So Dr. Skelton, if you'll let us know.
Sure. So I am a Houston native, so I am back where I began. I did undergrad at the University of Texas at Dallas, where I was a neuroscience major. So I always kind of had an interest in the brain, the spinal cord, kind of, neural function, but I'm a big picture kind of gal and wanted to know how all that put together. So wound up doing medical school back at Baylor College of Medicine in Houston. Kind of knew I wanted to do PM&R pretty early on. Wasn't sure kind of what subspecialty yet, but was interested in neurorehabilitation. I knew that much. So I ended up doing a residency at the University of Washington in Seattle. That was really fun. I was one of the categorical residents up there and was chief resident there my last year. Came back down to Houston and to Baylor for my spinal cord injury fellowship. And then had gotten bit by the research bug by then. So did a 2-year health services research postdoc fellowship through the VA. The VA really supports health services research. It's one of their kind of main research and development cores, and so was able to kind of get the mentoring experience and the writing experiences, get some more publications under my belt, and I was able to kind of apply and successfully get a health services R&D career development award, which is like a mentor training grant for 5 years. And so that's what I've been doing for the past 4 years now, almost 4 years. I guess I'll be 4 years in November. And so I am a clinician scientist at the Houston VA. I actually spend 75% of my time doing research. I'm working on a couple of different projects. My main project that my CDA was funded on was basically looking at how best practices for managing urinary tract infections and urine in the bacteria after spinal cord injury, and kind of looking at some of the processes and guidelines that we do around that. But I've also kind of branched out into telehealth recently with mental health and primary care, just kind of looking at how we deliver primary care to people with spinal cord injury, and also working on some really interesting things about health disparities, as Sheena or Shanicia, because that's awesome. I'm going to use that now. We're mentioning, because that's my passion. Obviously, as a woman of color in spinal cord injury, it's a very, very narrow definition of me, and so like I'm just trying to bring as many people as I can into the fold and into this specialty. I teach. I'm the assistant program director for our spinal cord injury fellowship, and so I work a lot with the fellows, and I do didactics to the give didactics to the residents, which I really, really enjoy. Was doing that on Friday. I don't really do much administration outside of the fellowship stuff, which is how I like it. And so I think, and then I guess for my clinical practice, that's the last thing out of the stuff that I do on a day-to-day on a day-to-day basis. I work with our home-based primary care team here at Houston, which is a little bit unique to the VA, in that, you know, we're primary care doc for people with spinal cord injury, which is really, really weird for a physiatrist, but I actually really, really enjoy it. And then I am a primary care doc for a subset of patients that live at home, but kind of only marginally so. And so we do a lot of case management and skilled nursing and support to keep those folks at home and keep them safe and keep them healthy. So that's in a nutshell what I do.
Great.
That is awesome. Dr. Vrooman, tell us a little bit more. We already told where you went to residency.
Yeah, absolutely. I was going to say, I'm probably one of the people that used Shanisha the longest, right? I mean, because you guys weren't Shanisha till you got to Baylor.
We weren't. Dr. Hamilton, our program director, coined us Shanisha because we were always together. So she's like, what's Shanisha? So yes, you did get to see the origin of that.
So mine's been an interesting path. I grew up really rural, didn't have any doctors in the family or anybody that I knew. Somebody in my family had a chronic pain experience, and I actually thought I was going to go into chronic pain. And so went to college in Southern California, actually majored in psychology, recognizing sort of that paradigm and the imperative of psychological health in a chronic pain picture. Ended up going to LMU DCOM out in Tennessee. I was one of the inaugural classes out there in a brand new med school. The cool thing about going to a school that was not associated with a hospital is you actually got to do a lot of the legwork and make your rotations yourself. So if you were proactive about it, you could really get a cool experience. And so, you know, we ended up like moving all over the country. I think I was married at the time. I had one kid. We loaded the kid and all of our stuff into a pickup truck, and we moved like every 4 months to a different part of the country to do all away rotations. And it was really funny because I would pick them based on like my family living there or my husband's family living there. And it's like, while we're in this city, is there somebody really good? Like, oh, there's like the best rheumatologist in the state of Arizona is in Phoenix. Let's go visit your family in Phoenix and I'll get a rheumatology rotation set up. So it ended up being a really eclectic mix. One of my upper levels in medical school was from Dallas. She was a Dallas native. And so she similarly was setting up away rotations near her home. Ended up rotating in the Baylor PM&R program because she wanted to be near home and was looking at sports med. She actually ended up going, doing the family medicine route and then sports med that way. And
I talk to her all the time, which is
I know, so right. So she is the reason that I came to Baylor. But I came out and did a really early elective in my PGY 3-year, or MS 3-year, OMS 3-year, fell in love with it. One of my funniest Hamiltonisms, if people know Baylor, is my first day on rotation with Rita Hamilton was the day after the Mavericks won the championship. And our sublet was across the street from the American Airlines Center.
Oh, nice.
And so there was like partying in the street until 2-3 o'clock in the morning, like bullhorns and cars honking. And, you know, I had a 1-year-old at the time and my 1-year-old was not sleeping. Like I still, if you have me on Facebook, I still have like a video of like the streets outside the American Airlines the night after the Mavs won. And so I remember going in and I was really sleep deprived and I was terrified, like I'm going to make the worst impression ever on this woman. And she was so excited. I don't think it would have mattered how I did. I mean, it was like the floor to ceiling Dirk Nowitzki and you know, the custom Mav pants. I love you, Dr. Hamilton, if you ever see this, but, and I say this with the most respect, but it was, I knew I wanted to go there. So I did a preliminary internship year, not far from my medical school. And then went to Baylor Dallas. Actually, when I started there, I did not plan on going into spinal cord injury. I still had, at that point, kind of planned on going into pain at some point. And I really do give Dr. Hamilton a lot of credit. If you guys have spent time with her, she's incredible, and she's inspiring, and she's so real with her patients. And I loved that about her. And I love the energy and the interaction. You know, I love the opportunity to teach and to teach everybody. And so, you know, I really am passionate about teaching. And in our program, it's like teaching and baking were the two things I was known for. And so I kind of found a natural niche with spinal cord injury. I ended up going to the Houston program. You know, I kind of didn't want to move that far away. I'd added a couple more kids by that point. And then came to San Antonio as an attending, and it's been a lot of fun. You know, I've been here, I'm going into my 4th year now. And so I'm full-time VA, and then I'm super 8th over at University Hospital. So I'm an assistant professor with UTUSCA, if we have anybody from UTUSCA watching, and I'm super involved with the residents. What's that?
I didn't realize that that's how you pronounce the acronym. Like,
Me neither. And I was like, oh, okay, me too. I was like, oh, that makes sense.
But like, I didn't know.
UT Health San Antonio for those.
Yes, yes, UT Health Science Center San Antonio, UTUSCA. You know, and we have an incredible faculty basis there. It's a lot of young, energetic, passionate attendings. And you guys got the pleasure of interviewing our new chairwoman, I think last week.
Yeah, she's doing great.
Who's a perfect fit for us as far as youthful and passionate and just on fire. You know, we're blessed with incredible residents. I spend a lot of time teaching. I'm the academic faculty advisor for our program. So I work like this with our academic chief resident and the integrity of the didactics. I am the module director for our spinal cord injury module whenever it comes up every 12 to 18 months. You know, I have great other attendings in my spinal cord department at the VA that are just a joy to work with, and some of the highlights of my job. I've recently started dipping my toe into the medical school as well. So I have an official Veritas faculty mentorship role at the Long School of Medicine, getting in everybody's brains early and teaching them about physiatry and spinal cord injury medicine. Yeah. You know, it every time I'm like, you're interested in this. Well, let me relate it to spinal cord injury. So it's awesome for me. You know, I have clinical, I have teaching and mentorship. I do have more administrative than what Dr. Skelton had described. You know, just kind of overseeing some of our day-to-day outpatient clinic operations. One of the things that goes along with being the primary care service for spinal cord injury is there is a lot more administrative stuff generated. All of the equipment evaluations and referrals and home health referrals, and just you're going to have, you know, there's goods and bads to every job. So, you know, and you're going to have some red tape. Like at the VA, I never have to fight for Botox. If I see somebody in clinic and I want a Botox, I just pick up the phone and call my pharmacist. Yeah. I'm like, yeah, I need 800 units of Botox. And she's like, sure thing, Dr. Vrooman. Never going to happen on the outpatient side, but there is a little more of the paperwork, and you know, we're transitioning in the next couple years from CPRS to Cerner, which is going to be interesting for all the VA docs. Right. You know, the San Antonio VA is a little bit different too. By and large, you know, I haven't compared like the data, but I think we have a younger population because we have the big polytrauma center. We have BAMC, we have a lot of military bases. And so that was one of the biggest surprises for me when I first came out and started, is I went, wow, you know, they have a lot more young acute injuries in San Antonio than I'm used to seeing in like the VA SCI population in general.
Yeah. Well, I also want to say, I want to thank you guys for taking care of such a wonderful population. I think it's amazing, and thank you guys for your service for them.
Yeah. Yep.
Yeah, I come from well, I mean, I think we both do technically, but a military family,
Military family.
you know, several generations of people in the military, you know, family in the military. And it's just, you know, the mission at the VA is simple, you know, is to care for those aboard the battle. And
Yep.
so I'm a very mission driven person, and that's a mission
Perfect.
I can,
We can get behind that mission.
yeah, it's a mission I
Yeah.
can-
So
I
I
love it.
wasn't in the military myself, but my husband was deployed in 2002 to Iraq, and his dad was in the Marine Corps for 30 years before that. And he's actually had somebody in his family in every single war that the U.S. has fought in
Wow.
since the Revolutionary War.
Wow.
So very, very proud military heritage there. You know, and it matters, you know, when I'm trying to connect to patients. I wear a U.S. Marine Corps lanyard, and I get asked about it, and it does make a difference to them that you are there for the right reasons, and you
Yeah, that
understand.
personal connection.
Yeah.
That makes sense.
And of course, the Marine Corps is so small. Like, Marines are a particular flavor. And so the Marines in particular love that I'm married to a Marine. They're like, oh, you get us.
Yeah.
And and it's a small enough group that I've actually met one of my patients that actually served with my father-in-law.
Wow.
Yeah, it was really interesting.
Cool. That's cool. That's very cool.
Great. All right. So Angela, you talked about, you know, talking to those medical students and, you know, getting that exposure to physiatry early, which unfortunately we don't often see that. You know, people are exposed in their not PGY. I did the same thing you did, their third and fourth year of medical school. And so if you guys can kind of just briefly talk about, you know, when were you exposed to PM&R? How did you get interested in that? And then why did you choose spinal cord injury medicine in particular to subspecialize in?
Yeah. So I didn't realize how fortunate I was, but one of our OMM professors in my medical school is really well known in PM&R, Dr. Michael Whiting. And so we had exposure to him really early on in terms of musculoskeletal exam and osteopathic manipulation. But I mean, I don't think any medical student at that point can get the full breadth of PM&R. And so I remember one moment for me was during my third year medical student core rotation, finishing up 2 months in the ICU. And we had a patient that, you know, the typical bad story. I mean, he'd been septic and been on dialysis and barely made it. And it was like the last day of my rotation. It was rural Tennessee. There really wasn't rehab out there. And I remember having a very heartbreaking conversation with him where he was very grateful and genuinely appreciative of us really saving his life. But saying, you know, I'm going home today and I can't work and nobody else from my family is making an income. And I'm going to need help and I don't know how everybody's going to help. And it took a day and a moment that was such a victory, and then was like, whoa, wait a minute, like we missed something. There's something we're not doing. There's something that's not being offered to this man. And that was when I circled back and was like, wait a minute, tell me more about this rehab stuff. Cause I know it does musculoskeletal and I know you can do OMM and all of this, but you know, this guy really needs help with this bridge and this transition. And so that was kind of my moment that I was like, no, that's the route that I need to take. And even though I was still thinking like pain management at that point, I was like, this is going to give me a lot better exposure and an all around view of the patient and the challenges that they present.
Yeah, we're always thinking outside the hospital stay, right? We're like, what's the next step?
Yeah.
They can't walk. Like they can't leave the hospital. They can't walk. So
Fix them, but now what?
no, right,
Yep.
exactly.
Yep.
So I actually got into PM&R when I was at UT Dallas, which again, I think we're all at least Texas adjacent here. People are probably very confused about the whole Baylor Dallas and Baylor College of Medicine and Baylor.
They are. Yes.
Mhm.
Take a minute to do that. So
Yes,
there's
please do.
Baylor University in Waco, which is not affiliated to Baylor College of Medicine, which is in Houston, which is also not affiliated to Baylor in Dallas, where y'all all went to residency.
Right. So
Not
we
very
both
prolific.
have two Baylors, Dr. Skelton, and they're not
Very
the same Baylors.
prolific. So just
Yeah.
trying to get the map. And so
Yeah.
I did undergrad at the University of Texas at Dallas. It's one of the affiliates there. So all Dallas adjacent here. And so, like I said, I was a neuroscience major. I was doing some preclinicals. I actually did, they had this, it's called a Parkland Collegiate Fellow. And so you spent the summer working at Parkland. You got assigned to a clinic. I remember I got assigned to the kind of chronic kidney disease and dialysis clinic. So for 3 months, I was working a 40-hour gig, kind of going up there, working in that clinic, shadowing. It was a lot of shadowing, but it was also, taking vitals and just like anything that they had me doing in the clinic. And I just remember I spent a lot of time talking to the docs there. I spent a lot of time talking to the nurses, because that was the thing. It was supposed to be a really immersive experience, so that you could have, a good idea of what medicine was like. And I remember just being very disillusioned after that summer. And I just was really not sure if medicine was what I wanted it to be, if that's what it looked like. Like everybody just seemed really hurried, and you didn't get a whole lot of time to spend with your patients. And I just was really, really concerned that I wasn't going to be fulfilled doing that. And so I remember going back and talking to my advisor at UTD. And I told him what I was interested in. And I was like, oh, well, maybe I want to, I had started learning about rehab psychology for some reason. I don't know why. I guess because I was our college was in the School of Behavioral and Brain Sciences. And so I talked to a lot of psychologists, and I was just like, well, maybe this is what I want to do, because I like the idea of like rehabilitation and function and thinking globally about a person. And he was like, well, if you're still interested in medicine, if you're not going to give up on medicine yet, have you ever heard of TIR, the Texas Institute of Rehabilitation and Research? And I was like, no, what is that? And he was like, go to their website, look at it, and I think it's something that you'll like. I think it's something that you'll be interested in. Just give it a shot. Don't give up on medicine yet. And so I remember going to that website, and I was clicking through, and I was like, oh, this is interesting. And I remember I clicked on like the definition of a spinal cord injury doc. I'm like, ooh, they treat all the organ systems. Like all the organ systems are affected. And oh, that's interesting. Look, they work as a team. Oh, that's cool. That's neat. That's neat. And this person, they've had this devastating injury, and they're like, oh, well, that's great. That's wonderful. That's wonderful. This sounds amazing. This is amazing. And so I actually was one of those rare few that went into medical school knowing that I wanted to do PM&R. I wasn't 100% sold on spinal cord injury, but residency sold me on that. Again, I spent my first 3 months of my PGY 2-year at Harborview in Seattle, which is the big county hospital up there. It's kind of wild. It's the only level 1 trauma hospital for 5 states. Not 5 counties, not 5 cities, 5 states. People get airlifted from Alaska to come to Seattle and come to Harborview.
I did not realize that. That just blew my mind.
Yeah, it's wild. It's wild.
Yeah.
It's crazy. I mean, when living in Houston, when there's 2, blocks.
Right. I was like, in Texas, there's a million level 1.
Kind of wild, but it's a great place to train, and that you see everything. Like literally all the trauma cases come through Harborview. And so I spent 3 months there. And one of my most interesting patients, he lived in rural Montana, and so came here for a scoliosis surgery actually, because he had a Charcot joint. And so he had been living with like a Asian Pyramid Scale C scale injury for a while, but was starting to get scoliosis. And so they came and did a reconstructive surgery. It was a big giant surgery when the orthopedic surgeons did it. And he actually lost some function, was on a vent for a while because it was just this big surgery. And so he was so anxious and was trying to get off the vent. And like, it was a lot of coaching and hand holding and telling him it's going to be okay, and looking at things. And but then there was also a lot of medicine, and then also in the middle of that trying to rehab him too. And so he finally got off the vent. He finally got, he regained a lot of function back. And I just remember when he left to go back to rural Montana with no resources, but we pieced something together for him. He was just like, I want you, for the rest of your career, Dr. Skelton, I just want you to tell other patients to not give up, just like you told me, just like you never told me to give up, just like you never let me quit, you know, when I was scared, when I thought I was drowning in my own secretions, when I thought I would never get off this ventilator, you wouldn't let me give up. And I just like, okay, yeah, that's what I want to do. That's what I want to do. So that's the neat thing about spinal cord injury, is that you're whatever your patient needs you to be that day. Sometimes it's a coach, sometimes it's a cheerleader, sometimes it's a physician, sometimes it's a social worker, sometimes
It's true.
it's a friend. You're whatever your patient needs that day, you know, to help them achieve the goal and kind of get back from this catastrophic illness. And so I find that really rewarding. And the scientific inquiry about it, man, it's the last frontier. You know, the neuro recovery and the central nervous system is the last frontier. And even if, you know, I'm not doing kind of basic sciencey type things, how we deliver care to this patient population, they're small but costly. And so we should be, you know, we live in a world of finite resources, and so it's up to us to be good stewards of those resources. That's the whole kind of premise behind health services research. And so I just want our guys and gals to get the best care, and the evidence-based care, and, you know, effective and efficient care, just like any other patient population. So it's
I love it. Good. So did you guys always want to work in the VA, and how did you decide on your current position? Felicia, if you want to go.
No, it's a short story.
Right.
So this is my first job out, and I tell people this all the time, like I kind of completely fell into the position that I have right now. Like so like I gotten bit by the research bug. I'd been doing the RMSTP through AAP all through residency. When I went down and interviewed for my fellowship, I wound up talking to Dr. McDevitt, who was the chair of Baylor at the time, and Dr. Francisco, who was the chair of UT at the time, kind of telling him, you know, these are my plans. I really want to try to make a go of clinician scientist. I want to stay at Houston. You know, what opportunities are there for me? And there was a lot of, oh yeah, we support, yeah. But there was nothing solid
materializing.
At all. Nothing. And so, you know, started fellowship, and, you know, because I was the Baylor fellow, so I started at the VA, and, you know, was working with Dr. Holmes and everybody down there, and was talking with Dr. McDevitt on the side about, yeah, I would really like to stay at Baylor, and I really kind of want to make a go of this whole clinician scientist thing. What does this look like? And I enjoyed my time at the VA. I really kind of felt, you know, like we were talking about, the patient population is really fun and they keep you on your toes. So honestly, it was one of those things to where, like, my mentors for my research were working at the health services research division that I'm at. It's called, the VA love their acronyms. And so our HSR&D coin, the health service research studies, is called the Center for Innovations in Quality, Effectiveness, and Safety, or IQEST. Let's just say IQEST for now on.
Right.
So my mentors worked at IQEST and were like, well, you could do this kind of postdoc fellowship. It would, you know, you won't get paid much. And I was like, and so I was really tired of being a president.
I know, right? Right.
I was like, and so they're like, you won't get paid much, but you'll have protected time. And that's really what you need at this point in your career. If you really want to make a go about this, if you're serious about this, you need time. And so I went into this really weird hybrid role of me being this, you know, in the postdoc fellowship and then an attending at the VA. Dr. Holmes basically created a position that didn't exist for me to stay at the VA. And so I will forever be thankful and grateful to her for that. And then we were like, oh, well, you know what? We don't really have a home care person. We kind of just, everybody's kind of just, it's like not a thing. So now that we're bringing you on, you're going to kind of coalesce this and make it a thing. And so I was like, okay. And y'all know in our residency, we don't get a whole lot of outpatient continuity of care type things. And then I was a primary care doc for these really, really sick folks, you know, outpatient. I was just kind of like, oh my gosh, what am I doing? What did I get myself into? But I just made it work. I made it work with a lot of support. We made it work. And it's actually kind of my dream job. I actually really, really love what I'm doing, because again, I I spend my time doing the things that I really, really like to do, and I have minimized the things that I don't like to do, which is really nice. And so research is actually my creative outlet in medicine, because it's like, oh, I have this idea. I have this hypothesis, I'm going to test it. And if it doesn't work, that's okay. We'll think about other ways, and you kind of get creative and piece things together. I've become more uncomfortable with uncertainty than I ever thought that I would ever be. I've become more comfortable with failure and rejection than I ever thought that I would be because of my research career. But I also see patients. I have a motley crew, but I love those guys to death. And they are very, very understanding that I'm kind of bouncing back and forth and now like in cyberspace all day. And so I'm very, very appreciative of them. I work with a great group of nurses and therapists and social workers who, again, I could not do what I'm doing without them, because they are the glue that kind of keep everything together. Like when I'm bouncing back and forth and doing all the different things that I'm doing, and they're just an amazing team to work with. And again, we weren't really a team before I started. It was just kind of these disparate things, and people are saying, but we really are the home care team now. And so that I'm really proud of that and really happy about that. So yeah, it's fun. It's not at all what I envisioned that I would be doing 5 or 6 years ago, but I actually really love it.
Yeah, I think when doors and things are supposed to be and meant to be, it just kind of opens up easily and turns into usually something great when it's meant to be. So that's awesome. Very good. Angela, what about you? Was that always your plan?
So I really enjoyed internal medicine. Like when I did my internal medicine internship, it was in the VA, and they tried to convince me to stay and finish the second and third year. I'd already like signed my contract to go to Baylor. I was like, no, I'm going to be a PM&R doctor. But it was a tempting offer to stay and do internal medicine. So then when I found spinal cord injury, this was only like 8 months down the road. It's like, oh, you can still be an internal medicine doctor and a rehab doctor. And I always like fondly say spinal cord injury is like PM&R on steroids. Like it takes everything and just complicates it. Whether it be tone management or DME or any of the basic rehab principles, the psychology and interventional motivating, and just twists it all up. And I actually enjoy untwisting. So I liked that about the VA, that it was that you did have that primary care role, and I liked the resources. We are so blessed at the VA, and I live this world of parallel lives, because half a day a week I go to a county hospital, and it's like my county hospital. I have, very limited hardworking support staff, but it's very limited. And on the VA side, our department, when you include our amazing nursing team, is 100 strong. It's so much easier to get the equipment that they need. It's so much easier to get the mental health. We talk about healthcare inequalities, and trying to get mental health care in the private sector is so ridiculously difficult, and all of my people need it because nobody plans on having a spinal cord injury. And it's one of the most transformational moments you can go through. I actually really enjoy that moment and consider it a great honor to be a part of somebody's life at that moment, because you see such incredible resilience and families pulling together and making the best of a terrible situation. And I meet so many patients that have actually thought about, if I ever lost the ability to move my legs, I wouldn't want to live that way. And you meet them where they're at in their most vulnerable moment. And like Dr. Skelton said, you have that opportunity to be hope, to show them hope, to show them that it may not be the way it was before the accident, but that there's still meaning and purpose and love and joy and all of these things. And I really enjoy that aspect of medicine. So You know, that was a big pull for me, is the ability to care for patients in the way that it's different than the private sector side of things. My personal story absolutely played into it, my family, and you know, the wanting to serve and serve the country. This is a different way of service, but I do take it that way, that it is a way to serve my country by caring for veterans, you know, and honoring my family as well. You know, but, you know, when you look at spinal cord injury, it's like half the jobs are at the VA and about half of them are out in private sector if you really want to do spinal cord injury. So I always think it's good to get at least some experience in both. They have very different flavors. You know, like I said, the resources are really different. But if you want to get down to just practicality, because I think that sometimes we gloss over that with medical students and trainees, there's a lot of really practical reasons to choose a position at the VA. You know, the benefits are exceptional. You can still get a pension working for the VA. I came out of medical school with a lot of student loan debt. And it was federal student loan debt. So, you know, I'm in the public student loan forgiveness program that requires a nonprofit or government employer. So this is qualifying. And then the VA, in an effort to attain and attract the more competitive applicants and get a higher quality of doctor for veterans, has an educational debt repayment program they've started offering. And so it's for hard to fill positions, which spinal cord injury is like at the top of the list. I've talked to a couple of HR people and they're like, oh yeah, if I have a spinal cord slot, it's pretty much always EDRP eligible. But EDRP is actually really an incredible program. It's a direct reimbursement for money you've paid towards student loans. So they recently increased it. So it's $40,000 a year for 5 years. Which is hard to find on the private sector side of things. You know, so there's the idealism, there's the resources, there's the practicality of it. There's a lot of reasons to be employed at the VA. And I think, you know, we talk a lot about if you've seen one VA, you've seen one VA. Like there's a lot of variability from site to site. But I've been really blessed at our site in that we have really supportive leadership from the director to the chief of staff to the service chief level that really embrace that mission and that idealism of patient first. Do what's right for the patient first. We'll figure it out afterwards. And rewarding quality improvement and ingenuity and you know, just so many of those things that are hard to find.
Mm-hmm. Great. Well, let's kind of go back a little bit and talked about, you know, Benicia and I, we always talk about how spinal cord injury, that rotation is like the foundation for PM&R. You guys both touched about it a little bit in the sense that you learn everything on your rotation. You get a good, you know, education on the neuromusculoskeletal exam through the ASIA exam, learning about spasticity management, learning how to communicate with patients and family and all of that. So in terms of, we have a lot of students, medical students and residents that follow us. And so Angela, if you want to kind of give some advice, especially this year for medical students who either may be doing like virtual rotations, or if they, you know, are fortunate enough to do an in-person rotation, to know how to kind of excel on their rotation. And then Felicia, if we can kind of take the, you know, the next step in residency, you know, how if residents are interested in spinal cord injury medicine, you know, how do they become a competitive applicant?
Yeah, absolutely. So there are some things that are challenging about the pandemic, but there are also some really nice opportunities in the midst of the pandemic. You know, so I know one of the things that we've started doing is all of our lectures are virtual. You know, and that was a move we made so that we don't have all of our residents in one room and all getting each other infected. But because they're virtual, we're able to get lecturers that we would not otherwise be able to get. And we're also able to involve students that we would not otherwise be able to involve. And so that's been a really fun opportunity is you know, we regularly have medical students that join our didactic sessions. And we're very our residents are amazing, and they always take time, like in between the lecture slots, to just open up the Zoom session to Q&A and like tell us about yourselves and what you're interested in, and just getting to know people. You know, PM&R is people first. You know, I like the people in PM&R in spinal cord injury, and I hope that medical students will get that feel. Like we like other people, we like being around people, and we like to hear their stories. You know, so coming into spinal cord injury, gosh, don't worry about memorizing everything, because there are so many, like, we actually like that as spinal cord docs. We like the geek out moment, most of us, that like you could name an organ system and I can tell you like lots of things that are different about that organ system versus, you know, the non-injured. I'm like, it's like a whole nother type of human being. It's incredible. So I geek out on the physiology, and I certainly don't expect a student to know that. I want students that are interested and that are reading and asking good questions. And, you know, yeah, of course you want to, you know, brush up on, you know, basics, the PM&R secrets or the Cucurilla or whatever, because you're going to do that before you go on any rotation. But the attitude and the personality is more what I'm looking for. And I'm looking for the maturity. So, you know, do you come to it with learning objectives? Do you know what you want out of the rotation? You know, because I think that shows a different degree of forethought in a learner, that you're in a spot where you're less focused on, oh God, I want to perform, and more in that mindset of, I'm going to be a doctor. I'm going to take care of patients. And these people are the ones that are going to help me become the doctor I want to be. And so what can I learn from this individual? So that's always more impressive to me as students that come to my rotations, is that they're eager to learn and have a great personality and are forward thinking about what they want to learn in that rotation.
Great advice.
So for the residents, the PM&R residents that are interested in Spinal Cord Injury Fellowship, I hope that you're out there first and foremost. We just finished up our interview season for this year. It was virtual, which was very different. But I think I think it went well in general. We have great applicants every year, extremely smart, extremely bright, you know, have done a lot of things in residency. There's just not enough of y'all. And so I hope the residents that are looking today are you know, have seen how much, you know, you can do in spinal cord injury. Like anything you want to do in PM&R, you can really do from spinal cord injury. If you want to teach, if you want to do research, it's really, really a great field to go into. And again, it's small, and everybody's really cool, and everybody's really smart and really funny. And you have to kind of have a bit of a dark sense of humor to do spinal cord injury, I think, because, I mean, again, we take care of people with catastrophic disability. You can't take yourself too seriously. You can't take anything too seriously, because it can be over like that. And so
Poop, pee, and sex all day long.
Yeah, exactly. You're really, really comfortable with your sex talk. I told some like first year medical students, because this is a funny story. I'm going to take a little bit of a tangent here. Baylor College of Medicine has this class for first year medical students that's called Compassion in the Art of Medicine. And I gave a lecture to them a few months ago talking about developing self-compassion through taking care of people with disabilities. And so I told them like these different 5 life lessons. And one of them was like, you have to become comfortable with what makes you uncomfortable. Because how are you going to talk to other people about things if you're uncomfortable, if you're squirming? And I'm talking like, okay, y'all need to develop your sex talk. And they were like, what? And I'm like, your sex talk. How are you going to talk to somebody about, you know, their junk's not working anymore? You know, everything's different. They're awkward. They're scared. They don't know what's going on. And if you're awkward and scared and don't know what's going on, guess what? Nobody's going to be having sex. And they were all just kind of like, wait, what's happening? And so I was like, illustrative example. I digress. So now, if you're interested in fellowship, I tell our residents all the time, you have to know what you don't know and what you want to get out of a fellowship. It's 1 year. It's going to go by really, really fast. And so why are you going to take another year at a PGY stipend when you can go, again, especially if you trained at, you know, Baylor College of Medicine at UW. You know, we see a ton of people with spinal cord injury. you don't necessarily need to have a spinal cord injury fellowship to do that. Again, if you want to work in the VA, you kind of do. And especially getting that primary care aspect of it is going to be really important. But if that's maybe not where you see your future, so why are you going to take another year at a PGY5? You need to be able to articulate that very clearly, succinctly, passionately, make me believe it. And so I think that's really the biggest thing with fellowship. I think just like Dr. Vrooman was saying, there needs to be a certain level of maturity. You need to be ready to kind of step into that junior attending role, because I think that's what a lot of fellows are on their service. You're not doing the kind of day-to-day grunt work that a resident's doing. You're usually working with a resident that's doing that, but you're getting more into that supervisory role, that teaching role, and you need to kind of be at a place and show that you have that maturity to kind of step into that. And again, just know the programs that you're applying to, know what their strengths are, know what their weaknesses are. Again, a lot of folks are looking for that kind of mix of acute care, kind of private sector plus VA, because I think that's super important, because those really are the kind of the two big worlds in spinal cord injury, and you need exposure to both. And again, I wouldn't really want to imagine kind of trying to do the job that I did now without going to a spinal cord injury fellowship that had a strong kind of primary care outpatient exposure, because it would be extremely difficult. But you need to be aware of those things. You need to be knowledgeable of those things. You need to be able to articulate those things on your interview. So I think those are the most important.
I know, Angela, you kind of touched on this a little bit, just about the lifestyle and practice benefits of working in the VA, and kind of what your typical week looks like.
Yeah. So my typical week, I'm predominantly outpatient care. And so we do everything. I do annual exams. I do a lot of problem-based bowel and bladder type visits. We do wounds. We do spasticity injections. I'm really proud at our center. One of my colleagues took an early interest in fertility in males with spinal cord injury. And so we actually do penile vibratory stimulation and EEJ in our clinic. And are able to offer that as another service. We deal with AD on the spot. I have an amazing outpatient nurse team. Like that, it would never happen in the outpatient setting, but a patient comes in for a regular appointment, he's an AD, and my nurses are like, hey, okay, we'll put him in 5 and do a bowel program and get him cleaned out and nitropaste him, and he's going to be good to go before he goes. We get to really focus on the patient. There's not as much of the stress to push the numbers as what you see on the private sector. There's more of an emphasis on the quality of care. There's more wiggle room, that there's an acknowledgement that, okay, your SCI hub may be a 6-hour trip for a patient or a couple-hour trip for a patient. And, in a lot of settings, they say, okay, tell them to pick 1 or 2 things and you're going to address those 1 or 2 things. I'm very supported when I say, no, my patient had a really hard time getting here and it took them 2 hours to get ready and 2 hours to drive here. I'm going to sit there and go through every single problem that they need to go through and educate them. And I'm supported and given the time to do that. I don't think I would be happy in a place where I didn't have the time to do that. Because I feel like so much of what I do is sort of preventative, proactive, good health for people with spinal cord injury. Because again, just our lay public in general, a lot of folks don't have, or they can certainly improve their knowledge about preventative care and whole health and things like that. And even more in a spinal cord injury where their pathology is all different and their physiology is all different now. And you've got to teach them the normal and how theirs is different and then go from there. So that's, you have more time, which is really important. The other thing that I love about it is that the VA really does embrace education and research as part of their mission. And so it's not that uncommon to find people like me or like Dr. Skelton that, you know, are actually given support and protected time to do educational things or research type things. And a lot of times in the private sector, that's like what you do at the end of the day on top of everything else that you're doing. And so I think that the work-life balance can be a little bit better at the VA. You still have that patient experience, but you also are encouraged and given time to grow and develop and do these other things.
And so my week, my weeks look pretty similar, kind of pre-COVID to now, but there definitely have been some changes. Again, I think in addition to all the benefits that Angela had already talked about, I mean, you get all the federal holidays off. You get a lot of, you know, I don't remember how many weeks of paid leave that I have now, but you basically accrue it on a basis, on a, you know, pay period basis, and it's pretty generous. You know, the retirement benefits are pretty generous. The health insurance is nice. Again, you know, all those sorts of things. And so really great benefits as far as for just looking for an employer. And so my day to day, again, because like I was saying, I'm 75% research, 25% clinical. So what that winds up being is that, well, it's interesting. My clinic day is, I do that all day on Thursdays. And since mid-March, with everything with COVID, I've been 99% virtual. And so the VA, as people may or may not know, was really on the forefront of telemedicine and telehealth and had some infrastructure built into that already. And so I'm not going to sit here and say that the transition was seamless, because it was not, but it was, I think, an easier transition than it could have been in other.
So much easier on the VA than in the private sector.
There was still a fair amount of wailing and gnashing of teeth, but we have smoothed a lot of that out now. And so I actually really love it. Again, if my, you know, 80-year-old patients with hand impairments can hop on their smartphone and do a video visit, anybody can do it. And so I've enjoyed that immensely. And so that's what I do all day Thursday. And so I do my annual exams, my outpatient follow-ups. I don't do much toxin therapy these days. As some of the other docs at the it was too much, like and just being pulled in too many different directions. And so I mostly follow up on kind of the chronic care stuff that we do. And then the rest of my week is all sorts of things. I usually try to write a little bit in the morning. So if I'm working on a manuscript or a grant or something, that's what I'm doing for those first couple of hours in the morning. And then the rest of the day is kind of meeting with my different project teams, you know, kind of checking in with them and the research coordinators and seeing how things are moving along. You know, I are giving a presentation or, you know, teaching to these folks or, you know, again, it is a career development award. And so the whole idea of a mentored research grant like that is that you're supposed to be learning and because, you know, gaining the skills and the knowledge to become an independent researcher. And so, to my postdoc and at the first part of my CDA, I actually finished up my master's in clinical investigation. And so had some coursework and stuff that was due for that. And I've taken a couple of different courses during my CDA on kind of like intervention development and implementation science. I'm actually starting this workshop for that. And so I do a little bit of that mixed into the day. We have a weekly interdisciplinary team meeting on Tuesday afternoons. That's what I'm usually doing there. So again, we do it all virtually now. So it's like me and the nurses and the therapists and the psychologists, we all get together and kind of touch base on the patients that we need to talk about that this week. And so it's a lot of, again, even in virtual kind of COVID land, it's a lot of interaction and talking with folks and kind of moving the projects along, but also kind of, okay, if I'm working on this database, let me kind of get in here and, you know, get 2 solid hours in there so I can really try to figure out what I'm doing. If I'm working on this manuscript, let me write and let me do this. Or if I'm working on this presentation, let me write and do this. And so it's a nice mix of autonomy, kind of just doing my own thing and kind of setting my own schedule, but then also collaborating and interacting with people. And so every week is a little bit different because depending on what's going on and what's happening. And again, when you're a primary care doc, anything can happen. So you got to be
Emergencies pop
That's-
up.
It does. It sounds really cool. Well, this hour went by so fast. We have about 3 minutes left, so we have to get ready to wrap it up, unfortunately. So we ask everyone that comes on our show, if you were not a PM&R physician, what would you be? Angela.
I'd be a teacher. I don't know what kind of teacher at what level.
What you would be?
Yeah, I would teach.
I can totally see that for sure. What would you do? What would-
A linguist. I know it sounds a little bit strange, but I love different languages and the origin of words in different languages. And so I'd be like, a professor at some university, learning archaic languages. I'd be
I
studying
love
Zinc
that.
probably,
Nice.
elbow patch sweaters and jackets, the whole 9 yards.
I love that. That's a good one.
That's great.
Very good.
Well, this was great. You gave us lots of good information and lots of very interesting information. So thank you so much for joining us. So since we didn't get to have audience, ask any questions, if they do have any questions, what's the best way for them to contact you guys?
Please, please, please email me or reach out. I'm totally fine. I think I got tagged. I'm new to Instagram. I'm figuring it out.
I saw that you had one post.
I know you can find me there. Yeah, it was for the SCI Fellowship Q&A. My chairwoman, holler out to Dr. Gutierrez, wants us to all be on Instagram.
Good.
So going to be working on that. But you can get me at angela.vrooman@va.gov. And I really, really love teaching and mentorship. I can't stress that enough. Like I tell everybody that, like, it's not something anybody twists my arm into or forces me to do. I would never practice somewhere where I couldn't do a lot of teaching and mentorship. And like a yay high day for me is when I hear like from random people at different levels of my training. I had one day like this where I heard from somebody in my that I'd helped out when I was a resident, somebody I'd helped out when I was a fellow, and then one of my current residents all hit me up on like a day off asking me like guidance, and I was like, this is the best day ever.
Yay, that's good.
It's a very genuine offer if I can help it anyway.
She's awesome, you guys. How can they reach you, Felicia?
Email is also the best for me, and just to keep it simple, you can just do skeleton, so it's like skeleton without the second E at bcm.edu. So that's my Baylor email address. And if you @ me on Twitter, I'm fskeltonmd. I will get it. I'm not on there all that much, so you really do have to tag me in it or send me a message. But those are probably the best ways to reach me. I'm never on Instagram.
Awesome. Thank you, guys. We appreciate you.
All right. Thank you.